Good morning, everyone. Thank you so much for joining us for this webinar. We're going to be discussing Financing Global Health 2025, Cuts in Aid and the Future Outlook. This is based on research done by the Institute for Health Metrics and Evaluation at the University of Washington. I'm Rhonda Stewart, the Director of Global Impact at IHME. And I'd like to introduce our panelists who are going to be leading us through a really engaging discussion of where we are in terms of these cuts and what their impact is and what the way forward might be. So we're joined today by Dr. Angela Apiege, who is a research assistant professor at IHME and one of the authors of the report. She is the lead author of the findings and a presenter today. Dr. Ali Mokdad is a professor of health metrics sciences at IHME. We are also joined by Dr. Charles Birungi, who is an advisor for macroeconomic and fiscal policy, equitable financing practice policy, advocacy and knowledge branch at UNAIDS. Austin Peter Davis, who is a senior advisor for global health at NORAD, the Norwegian Agency for Development Cooperation. And then finally, we are joined by Tibika Shanmugarasa, Director of Advocacy, Community Health Impact Coalition. So thank you and welcome to all of the panelists and to our audience. So today's session is going to be interactive. We're going to be interspersing the discussion with some polls where we will allow the audience to weigh in on various topics. We will also leave time for Q&A at the end of the session. So if you do have questions, please put those in the Q&A. Okay, so with that said, let's get started with setting the scene on these cuts. Professor Mokdad, I will turn to you first. And let's talk a little bit about that aspect. Ali, you might be muted.
Good morning, everybody. It's a pleasure to be with you this morning. And I apologize, I have to leave early for another meeting. But I will set the stage briefly. I am with IHME, as Rhonda has just mentioned. And as you all know, we do the global burden of disease, 204 countries, where we do what's killing and ailing the population from 1990 to 2023, and we're working on 2025. But today I want to briefly introduce what the report that we have produced from IHME is all about. And I have one slide to share if I can, or Angela, can you put it up, or I should share my slides?
You can share it, or I would if it's not ready.
That's fine. So
Okay.
I have one slide to share with you, and I'll briefly talk about it. So as you all know, health aid has increased during the COVID-19, and after COVID-19, it started slightly to decline. However, what we are seeing in 2025, as Angela, my colleague, will discuss in further detail, there is a sharp decline, about 20% in assistance, global assistance. And the reasons for this assistance have been different by different country, but mainly we want to spend more money on, unfortunately, on arms and defense. We want to spend more money internally on our own problem. And also we would like the foreign aid to be more efficient. So several reasons have been provided, but you could see from this slide, there's a sharp decline from a 2021 where we peaked due to COVID-19. It's my honor to pass it to my colleague Angela to discuss more about this report and its finding. Over.
Thank you so much, Ali. I'm delighted to be able to share the results from a report that was released earlier this year. If I can have 1 minute to share my slides, we should be ready to go here.
And Angela, while you're getting your
Yes.
slides up, I just want to invite the audience to use the chat and to comment. Tell us how the aid cuts have impacted your work in the region where you're based. One of the really important and valuable aspects of this discussion develop a better understanding of how these cuts are playing out on the ground.
Okay. I'd start my presentation now then. With acknowledgement to a handful of people, because this work requires a team to complete. Uh, Special thanks to Joe Dillman, Hans Elliott, Carolyn Chong, Goli Chakalos, Steve Lim, and Chris Murray, who all contributed to the work that will be presented here. So, a quick outline. I'm going to give an overview of the Financing Global Health project itself. This is a long-standing project at IHME. And then I would focus on the results. That's the primary interest for this webinar and our projections for development assistance for health going forward. So, our Financing Global Health project has been in existence for almost 15 years now. It's one of uh, the reports that we produce is one of the flagship reports that comes out of IHME each year. Each year, we focus on a particular topic of importance around development assistance for health. For many timely reasons, this year we focused appropriately on the aid cuts, and so the project in itself aims to generate health spending estimates for all the sources of health spending. So we develop estimates for government health spending, prepaid private health spending, out-of-pocket spending, and development assistance for health itself. For the first three, that's the domestic spending part, government spending, prepaid, private, out-of-pocket payment. We have estimates that go till are 2 years lagged. So for 2025, we will have estimates till 2023. And these estimates are also projected forward. So we have forecasts of all of these sources of spending till 2050 for 204 countries. In addition to that, we have had some ad hoc projects looking at disease-specific domestic spending. So here we would be looking at spending related to particular disease areas, and in particular spending from the national government's perspective. And we'll have these estimates from for HIV, malaria, TB, immunization, and a handful of other health areas. Each is typically disaggregated by payer and is focused more on low and middle income countries. These are done generally on an ad hoc basis as we have funding for. And then the final source of funding, which is the focus of this presentation, is our estimates on development assistance for health. And that we also have the historic perspective, looking at data starting from 1990 till 2024, and then a forward-looking perspective as well, with projections going from 2025 through 2050. So, what do we typically include in our DAH estimates? We are currently tracking bilateral aid from the major OECD DAC countries and China. We also include data on the World Bank, both arms of the development branch, that's IDA and IBRD, the three regional development banks, Africa Development Bank, the Inter-American Development Bank, and the Asian Development Bank. 5 UN agencies. We pride ourselves in being more comprehensive by including more information on private foundations and NGOs development assistance. We cover grants and loans and include the administrative costs that will be associated with the management and deploying of the aid dollars. The framework we use to ground this work is from a resource flows perspective. And so we are looking at the flow of the resources from the originating source. And here we think of originating sources mainly as primary sources of funding. So a national treasury, a private philanthropist, or corporate donations. We include here as well debt repayments, largely because from the development bank perspective, some of the repayments that for debt will ultimately serve as sources of funding as well. And then we consider, I think, what most lay people will think of as sources actually as disbursing entities of development assistance. So that's the channels that's in the middle box. And here we are thinking of bilateral development assistance agencies, the UN agencies, the Global Fund, Public-Private Partnership, Global Fund, Gavi, foundations, and NGOs. And then ultimately, these resources will flow to a recipient institute, either a government program or a non-governmental program. And this could be national or university research institutions. My next two slides will set some context for why or how the potential impacts of the cuts. And this slide in particular is highlighting the areas around the globe that aid dependent. And so we're showing the percentage of total health spending that is sourced externally from donors globally. Our scale is increasing in intensity in the sense that the darker the shades, the higher the percent or proportion of a country's health spending that's coming from external sources. A key takeaway here, with the exception of a handful of very limited countries in outside Africa that may be a bit dependent on aid. The bulk or the majority of aid-dependent countries are in sub-Saharan Africa, with quite a number of countries having more than 40% of their total health spending being sourced externally. Another contextual insight that data on domestic spending on health for particular diseases can help us sort of situate the potential impacts as shown in this slide. So here, this figure is showing the proportion of total spending across the various health focus areas. So HIV/AIDS, TB, malaria, vaccines, and family planning, as well as the overall total spending in the health sector. But the percentages are showing the percent from different sources. So we have the dark blue as the US source development assistance, light blue as non-US source development assistance, and then the orange as domestic government spending. So that could be either government spending, out of pocket, or prepaid private. Whereas we see that in aggregate, if we're looking at the overall health sector, a lot of the funding is coming from domestic sources that could again be either government or out of pocket. So that depending on the actual source, that could be controversial or not. When we focus on particular disease areas, we see that HIV/AIDS, malaria, and to an extent, family planning, are particular areas for health that are sourcing a significant amount of their funding in low-income countries from the US. And so for HIV/AIDS, for example, we have almost 59% that was of HIV development, HIV spending that was sourced from the US. So this, points to some potential vulnerabilities there. All of that said, to give you some context, both for the broader project as well as for the potential impact. I will turn my attention now to the estimates that we generated for the report as well as the results. Before I do that, a couple caveats. The estimates I will highlight are based on observed disbursement or budget data through 2024. For 2025, given that we are still in 2025, we are reporting what we consider preliminary estimates using the best available information that would include statements from government or budget documents that have already been released. To generate these estimates, we are often assuming a lot of the announcements surrounding the aid cuts were made in relation to the overall envelope, that's the official development assistance. So we are assuming that those changes apply proportionally to development assistance for health in particular. And of course, we are aware that the announcements related to aid cuts change each day. All of that said, I will highlight the information that we used to assess the cuts. From the beginning of 2025, we have seen announcements from the US, UK, Germany, France, Belgium, Finland, the Netherlands, Switzerland, all highlighting potential or planned reductions or cuts in aid. I think in general, the narrative has focused more on the US because the cut in the US was significant and drastic. But it's important to note that a lot of the other major donors have also announced cuts in the current aid budget or aid budget for the next few years. Additionally, I wanted to note that we have updated, given that the situation is evolving, we have updated our data set since the report was released. As of November 15th, we have updated data, and that update included two important improvements. First, we use project level data that had information on the recipients and health focus areas from the terminated US aid and Department of State awards, so that we could get a little bit more specific in terms of what's happening at the recipient country level and health focus areas. We also, given the passage of time, the small budget information that have been released by the major donors, and so we updated our budget information for most of the other bilateral donors, except the US, because that was still under negotiation. Our first slide of results shows what we can see in terms of the patterns of aid for the major donors and what is the preliminary information we have regarding their aid cuts. And so we see that for most of the donors highlighted here, with the exception of Canada and Japan, we are expecting a decline in the aggregate amount of aid that has been provided. This figure is just a simple line figure that hopefully highlights how aid has evolved from 1990 through 2025. Of significant note is the extraordinary peak in 2021 as a result of the health response to the COVID pandemic. And so, whereas the aid development assistance for health was already on a declining trend towards pre-pandemic level. We note that 2025 has brought a significant acceleration to that of that decline to a level that is comparable to what was experienced in early 2000s, with a total development assistance for health projected or estimated to be around 36 billion. Our second results slide here as a table that highlights the various sources and disbursing entity. And I find this interesting because if you look according to the rows, you will find the main sources, and so the tallies at the end will tell you how much in aggregate they'll be. We're estimating that they will be providing in 2025, and then by column we see the disbursing entity. And so with that, you can see that in 2025, in terms of sources, we see that other governments as well as the Gates Foundation will become the top sources of development assistance. In terms of the entities that will be disbursing these funds, again, we are highlighting development banks, the Gates Foundation, and other foundations as well as NGOs, which all suggest a bit of a transition in terms of the main players in development assistance for health. Less of a focus now on the major bilaterals. The next few slides focus still on results, but we'll slice the data in different ways. And here, this figure in particular shows the development assistance provided from the various sources, highlighting the percent drops or decreases that we estimate across the different sources. So with the US in the bottom brown shading, we see that between 2024 and 2025, it's about a 66% drop. Private philanthropies will stay with a little drop, but relatively the same. We see Japan showing an increase, but for the most part, all the other major donors, UK, Germany, France, are estimating, for whom we are estimating a decrease. This slide just pulls out that information better with the bar figure on your left highlighting the aggregate decrease in millions or level space, and then to your right the percent drop. And so as we all are aware now, the biggest change both in terms of volume, aggregate volume and percent for 2025 is with the US. And we're projecting or estimating an increase, a slight increase with Japan. Similarly, for the disbursing entities, here's a stacked bar that highlights the evolution over time, particular emphasis on the estimated decreases across the various disbursing entities. Substantial changes for UN agencies, some for NGOs as well, and in particular the WHO, where we're estimating about a 24% drop. Again, the same information, but here pulling out a couple of the key disbursing entities so that the results stand out more clearly. Again, looking at the changes in level space as well as according to percent. And we see significant drops for NGOs, UN agencies, the WHO, and the development banks with um, substantial changes as well for some of the smaller agencies. Now we focus as well on health focus areas. And so the particular disease or health areas that we are estimating will see some decreases in funding. And here we're leveraging information from the terminated awards. And for that, we see that between 2024 and 2025, HIV, starting from the bottom, shows a decrease. Health system strengthen will have a decrease as well. And I think this figure will call out the changes more clearly. Health system strengthening, newborn, reproductive, and maternal health are all areas that will experience cuts or decreases in funding largely related to the termination of the various awards. Moving to a little bit here to sort of what we are estimating to be the impact at the recipient country level. And so this map is highlighting what we are calculating as the preliminary expected reduction in overall development assistance to various countries. And here, it will be helpful to keep in mind the figure I highlighted earlier, where I showed the countries that were donor dependent. And that sort of experience is replicated here, given the susceptibility of countries to external funding. So we see that a lot of the countries that will have reductions above 40% or even 20% for that matter are concentrated in sub-Saharan Africa, with South Africa showing a number of Southern African countries, if I would say, showing higher than 40% decrease in their development assistance for health. Continuing in that stream of thought, we calculated the implications of this in the overall health spending in the country if considering the reduced availability of development assistance for health. And while the story is a little more nuanced now, given that countries' health spending could come from various sources, either government or out-of-pocket spending, we see that there are slight differences between the previous slide where we highlighted the donor-dependent countries. Here, a lot of the impact in terms of reductions in overall health spending, right, is still concentrated in sub-Saharan Africa. But we see that the vulnerable countries are slightly different from what were highlighted in the preliminary donor dependent slide. Moving on to analysis that looked at or projected development assistance for health going forward. These are the methods that an overview of the methods that we use to generate the projections. We implemented any changes as has been described by a funder if there was any public statement made in terms of what the funder was planning to do going forward, that was considered. In countries where a given official development assistance was tied to their gross national income target, we assumed that there was a linear path to reach the target and held the ratio constant. If we didn't have such information for a country, we just held DH constant in real terms over time. And so this is a projection of development assistance for health in the near term till 2030. We see that the expectation is that the reduction in development assistance in 2025 will not necessarily fully recover. We will continue to be at a much more lower or reduced overall aggregate amount of development assistance than we historically have been. And so with that, these are the tools, all the information I have presented here are publicly available for users to download and use. We have an interactive visualization. We have country profiles that highlights individual country results, as well as a table, a CSV file of the actual estimates that you can download for your own analysis as well. Thank you. Now stop share. Can answer any questions as have come up.
Wonderful. Thank you so much, Angela. So I would invite everyone again to use the Q&A to submit their questions. And we've already in the chat gotten some really fantastic and interesting information about how these cuts have impacted the participants on the call and their work. And in a moment, I will ask the panelists to respond to Angela's presentation and what stands out to you and how you are seeing the impacts come across in your own work. I do also just want to remind everybody that, as Angela said, the data are all publicly available. I did put the link to the report in the chat. And so you are welcome to download the full report. We have interactive data visualizations and data sets that you can also download. Okay, so let me come to the panelists for your response before we go back to some questions. Tabika, let's come to you first, please. Tell us your response to the findings presented by Angela and how you've seen these findings play out in your own work.
Thank you so much, and thank you, Angela, for presenting. Really great to see the findings. Obviously, the findings themselves, not so great in terms of what it means for health and the communities that are affected. So let me just take a step back and share a little bit about Community Health Impact Coalition, who I'm representing today. So we are a movement of thousands of community health workers and dozens of health organizations in over 60 countries. And what we do is we work to ensure that community health workers who provide life-saving care outside of hospitals are recognized as professionals. So that means they're salaried, skilled, supervised, and supplied, and able to deliver reliable care. And for this to happen, we focus on winning national policies that recognize these community health workers as professionals. And because we know that many of these governments in low and middle income countries face tight fiscal space. What we've done over the past 6 years, we've worked with major bilateral and multilateral funders like USAID and Global Fund to expand financing for professional community health workers. Now, the findings from the report have major implications for our work. So in sub-Saharan Africa, 60% of funding for community health worker programs comes from donors. And because many of them are exactly the ones, Angela, that you presented, who are driving some of the major aid cuts, we're seeing community health workers and the communities that they serve really being hit hard. So some examples of this is you have community health workers who are no longer paid at all. Medicines are running out for the communities they serve. We see essential services for mothers and children disrupted. And because in many remote and conflict areas, community health workers are the only point of care, without support for them, we see access gaps widening, we see maternal deaths rising, and we also see that some treatable illnesses are becoming more fatal. But it's not all doom and gloom, and we are also seeing some promising trends. So I'll really briefly discuss them in terms of how our work is impacted by this. So because of these aid cuts, we've also seen some governments make huge changes in the way that they're spending domestically. So for example, Uganda and Kenya have increased their health budgets, specifically to strengthen community health services and support community health workers. In Kenya specifically, we've seen an increase in their community health budget by over 25%, and that means there's also some allocation to pay for community health workers. And these moves show that even when there are budget constraints, tight fiscal space, countries are finding ways to protect the foundations of their health systems. And at the same time, again, from the findings, we're seeing that some of these global funders like Gavi and Global Fund, they're also having to think about cuts. But when it comes to supporting some of these country-led community health worker priorities, they're also committing to supporting where we have very clear national priorities around community health workers. So the way that we've approached this is in terms of our work and facing and meeting the moment of these aid cuts. The approach is twofold. One is to protect existing wins that we've seen for community health worker funding, and two, diversifying resources. And at the global level, this means working with institutions like the World Bank, which provides on-budget financing for government's own health priorities. And at the national level, it's about supporting ministries of health to demonstrate why investing in community health workers delivers value for money, is cost-effective, and has a proven return on investment, so that we can make that compelling case for allocating more domestic resources. So together, these steps have helped us keep community health workers supported, and we hope that it can also create the conditions for more reliable funding in the future. And we see supporting community health workers not as optional, but central to resilient, effective health systems worldwide. So that's kind of my reflection and taking on board how that impacts the work that we do as Community Health Impact Coalition. Thank you.
Yeah, wonderful. Thank you so much, Topeka. And if anyone has a question or a comment on the vital role that community health workers play, or you want to follow up on something that Topeka just mentioned, please put that in the chat or the Q&A. And Peter, let me come to you next, please. Share your reflections on Angela's presentation and how you've seen these developments play out in your own work. Charles, let me come to you with that question next, please. Tell us how you have seen these findings play out in your own work and share your reflections on what Angela has presented.
Thanks very much, Angela and IHME, for this great public good that you've put out there to really shine a spotlight on a topical issue of our times. Just a couple of reflections from UNAIDS perspective and being based on the African continent, really reflecting what I'm seeing and what I'm hearing and what I see as the way forward. Really, for me, what the message, the key message from this report, that we are in the middle of a historical setback. I mean, a 21% cut in development assistance is basically for me not something that we can plug overnight. So it leaves a huge vacuum that can't be filled overnight. And with projections showing that that is poised to continue into the future, I think it's a big threat to the gains and the lives that we care deeply about. But of this 9 billion, I'm calling it a 9 billion hole. I remember when I first read the report. For me, Sub-Saharan Africa is the hardest hit region in this 9 billion hole. And I've lived and worked in some of the countries that we are flagged in the report, like Malawi. These are really countries that are fiscally constrained, very vulnerable. And I think what we will see is a great divergence beginning to grow. For example, one of the things that struck me in the report was this almost 300 times spent by high income countries compared per person per year compared to low income countries. For me, it's really we've been working, I think, over the last 2 decades to come to a convergence and really drive this global convergence. And I think these abrupt cuts that we've seen over the last few months are really going to lead to a great divergence. Instead of closing the gap, what is going to happen is really the bridge is being dismantled. And in many ways, I want to argue that development assistance has been a bridge. And Angela presented one slide that showed how different programs, health programs get funded. And for me, that what is striking is as UNAIDS, we work on HIV, mostly in low and middle income countries. And it's funded differently. It's more dependent than broader health, as it were. And what I think is happening, NGOs and the multilateral system is facing the hardest hit. And I must emphasize that in many contexts, they're the ones that deliver the last mile to a mother in Ghana, to a displaced child in Sudan. So that's really what we are beginning to see quite concretely. But let me say what we anticipate as really impacts in a more concrete manner is lives at risk, the gains of the past decades at stake. I mean, at UNAIDS, we know, for example, between 2010 and now, we've had like a 40% decline in new HIV infections. That's really at risk. So for me, it's not just a budget cut. It's really in some contexts, it is a death sentence. But just to and the service disruptions. Tibika mentioned some of the service disruptions. In a report we just released ahead of World AIDS Day last week, we've put together what those disruptions we've seen in countries. I mean, we've seen countries like Uganda, Nigeria drop the ball on very efficacious interventions like PrEP. And I think those are going to have implications. And there is certainly a human toll and economic fallout. But let me say, all is not lost. We're seeing countries holding steady and countries being very resilient. I think conversations we've always postponed are beginning to happen. I just came from Kigali, where we're thinking and discussing what ought to be the new architecture for health. Really, that shifts from dependency to more sovereignty. I mean, the president of Ghana, His Excellency Mahama, just launched this Accra Reset, where really African countries are galvanizing and really to really move the continent away from the dependence, because it's put us in such a bad place to have to think about replacing what was a relatively stable source to in a very short period. I mean, it's an irresponsible transition, to say the least. But so it's going to be, I'm seeing a lot of doubling down on efficiency. From an HIV perspective, I'm seeing a huge revolution for prevention happening. We're seeing countries punching above their weight. I mean, we've just saw the first rollout of lenacapavir, I think last week on the African continent to really do things differently. But we are seeing a lot of community resilience from places like Uganda, where the national government says, okay, instead of the network of people closing, we'll provide you space in a government office so that you're able to continue delivering this life-saving service that you've been delivering. So I see a lot of resilience on the financing front. I mean, we've heard from the Nigeria making bold announcements. We saw South Africa, the most heavily burdened country, stepping up and plugging the gap. But we are seeing countries introducing health taxes as a low-hanging fruit that is helping to bridge the gap. It won't close it, but it's a move in the right direction, and countries taking ownership of their agenda. Thanks.
Wonderful. Thank you so much, Charles. If anyone has any questions or comments on what Charles just shared, please add those also to the Q&A. Particularly the really very real prospect of progress being rolled back and what that might mean, for example. So before we come to some audience questions, let me come to you, Austin, and ask you to share your reflections on what Angela shared and how you have seen these results play out in your own work.
Great, thanks. I'll try not to repeat the other two. So I work for the Norwegians, and we're one of those countries that Angela showed that hasn't declined its budget. It's been a fairly steadfast investor. And our jobs are to manage aid contracts, but also to advise our Ministry of Foreign Affairs. So we're looking at it slightly differently from the other two, and clearly the first one is the impact on patients or citizens of different countries, and I think that's really only starting to become evident. I think the first wave of discussion was all about institutions getting mauled, USAID closing down very suddenly and colleagues being knocked out, contracts with different agencies being shut, WHO having to lay off staff. But also some of the aid-giving agencies like DFID is going through, FCDO is going through a major restructuring. So surprisingly, I think the first wave of noise has been the aid industry rather than the victims. But and what that I think expresses. So first of all, I would say, thanks for your reports, but thanks for them over time. So what we've seen is there's been some sense of unease since around 2015. So aid budgets haven't gone up, and more and more activities, more and more agencies, so more and more fragmentation without increasing budget. And that's led to, I think, a real crisis in the sort of sense of purpose, effectiveness and governance of global health aid, even before. And then you get the COVID crisis and all the cries about injustice and vaccine apartheid that undermine. And now this. And it's really the sort of end of an era. And I really think we're only just at the beginning of trying to work out what this means. So yes, the money is going down, but it's also shattered a kind of consensus where donors tried to work together in different platforms and finance things together. And the US has been the leader of global health for the last 20 years, by far. And the way that the US has thought about global health has dominated practice and thinking to an extraordinary extent. And I won't go into that now, but if people want to question about it, but it's been very, very important for good and for bad around how we think about the job of global health. So that's crumbling, and lots of the agencies in the field are crumbling, and the collaborations are crumbling. I saw someone had a question about Russia and China. Yes, they do give aid, not through the same platforms though. So we're seeing the beginning of a reformation of why we give aid. What's the purpose of aid? Who's going to give aid? Who's responsible for it? And what the partnerships are at country level. And as some of the speakers have mentioned, there has been a response by countries and stepping up. And even prior to this, there have been more and more calls by African public health elites to resurrect sovereignty over national health systems. So this is happening, and it's difficult to know exactly where it will go. And I think that some things that the report can't capture because your data tends to project forward. Like I was looking at your 23 report, and we were at the very low end. You gave scenarios in 23. We're at the very low end. And you have a very flat line to 2030. That's fine if we follow the historical data, but there was a leak from the EU of a possible complete exit from global health. So that was what I'm saying. The idea of global health is being challenged, and that idea may mean sudden real changes. The other thing is global health will continue without grant aid. We overestimate how it's only in the last 30 years that global health and grant aid have been so synonymous. Before that, there wasn't so much development aid going to global health, but agreements on pandemic response, with various treaties, tobacco stuff. There is a practice, and a lot of that practice is around science and R&D. And we underestimate the importance of declining budgets in R&D and changing roles of global regulatory agencies because we don't count them in ODA. So again, this kind of contributes to the notion. So if the US gets out of vaccine research and development, for example, that might have a bigger impact on global health than all the aid cuts. If we completely undermine one of the most important public health tools of the last century. So those are the sort of things we're looking at, and what we're looking at is how do we navigate, which platforms will survive and which partnerships will survive and where to put money. It's not just about money going down, but how do you rebuild a sense of collaboration, a sense of responsibility and partnership, and we're by no means at the end of that. And I would love to see some of your data disaggregated by humanitarian and development expenditure. That's crossed over. It was more development expenditure in the UN system till about 2017, and there's been a replacement there. A lot of money is going towards climate and global public goods. So there are all these different pots competing for the same small amount of money. We all blame rearmaments and stuff, but even before it was about, is it climate change? Is it humanitarian? Is it development spend? And I think that that confusion, you don't do climate change in the same way that you do delivering vaccines out to kids. But we're using the same agencies and same financing channels and the same governance methods. And I think all of us have seen complaints about governance. So it's really important. It's really important, as both speakers have mentioned, to see the positive sides and to try and emphasize those. Countries stepping up, taking back sovereign control. It's also really important to see the countries that may be suffering to a point where they can't step up. Maybe Mozambique, maybe Malawi. I think Centre for Global Development just released a report on Sierra Leone, really calling out one country. So there are those elements as well. That's probably enough for me now. I can go on. I've got sheets of notes here. It's like NATO, and America leaves NATO and all the Europeans are running around going, now what? It's a bit like that. Thank you.
Indeed. Now what? Thank you, Austin. We will get into that a little bit more in the session. If anyone has any questions or comments for what Austin shared, please add those to the Q&A as well. And let's actually go to some audience questions. And some of what Austin just shared, I think, is a good segue. So we did get a question about China, for example, and Russia doing DHA. And Austin, you mentioned that they don't really perhaps do it in the way that we typically think of DHA. Can you elaborate on that a little bit? DAH.
DH.
Yeah.
Okay, as an example, at the beginning of the COVID outbreak, the largest provider of vaccines was China. Totally shocked the world. Nobody saw China as a major vaccine producer. They weren't the most efficacious vaccines. So as the volume production in other vaccines came up, no one wanted them anymore. But they were early and they were massive, and they were given to countries in a cooperative way, where China had a cooperative agreement. So that was very important. And Russia tends to have bilateral deals, but both of them, China is a very significant financier of the UN system, a very significant financier. And with the US cuts, they announced that they were going to put $500 million extra into WHO, for example. So some of the international platforms are financed by other countries. The other thing is we see more and more aid from countries that you won't, Norway's in the other box on your grant, but there are lots of others. There is the UAE, or there is Qatar, or there is Turkey, or so there are many other groups who are coming in with aid, and they don't necessarily see the advantage of working under the framework of what has been traditional aid structures, OECD, DAC, and the UN. They're trying to give it in a different way, a different sort of sense of solidarity, a different sense of standards. And which is good and bad. It's both a fracturing. I mean, the debt problem is also much more fragmented, and so much more difficult to renegotiate debt restructuring. So it's a good and bad sort of set of conditions. And what this inevitably does, because there is no architect. We talk about global health architecture, but there's no architect. And the results at the end will be the sum of lots of different decisions. And the more that we can get together and talk and try and create new consensuses, those decisions may or may not be aligned. But we're not all going to get together and decide together. It just doesn't work like that. So what that kind of anarchy means is that this will throw more and more responsibility back to countries. Country governments will have to learn how to navigate these increasingly difficult seas, and hopefully learn how to take advantage of these increasingly difficult seas. Right now, I think tomorrow in Japan, the World Bank is announcing 20 new country compacts where they are negotiating much more two-way compacts for investment in health in 20 countries. But so is the US. So I don't know how that's captured in your spending, but the US has started a 2-week whirlwind tour going around countries with their own compacts, which basically said, we're not going to put money through NGOs anymore. It doesn't deliver sustainability. We're going to put money through government systems. And what we want from this is we want to see progress, and we want you to recognize that we're going to get out of here in 3 to 5 years, and we want access to your pandemic samples for our own protection. And most people are very worried about this, but there is a resurgence of an American-led, very unilateral approach. So that's up to countries to navigate. Norway doesn't participate in the room when these countries sign those deals with the US, as an example.
Interesting. And so there's a question in the chat that also picks up on what you were just mentioning, Austin. And the question, and Angela, you can chime in on this as well, is do you know what the US is or will be funding? So we've heard quite a bit about what the US is not going to be funding, for example, but what is your sense of what the US will continue to fund?
Well, they just pledged last week to the Global Fund for AIDS, TB, and Malaria. And they are doing these country compacts through PEPFAR. So what are they funding? They're continuing to fund HIV with TB and malaria as side events, but a really big focus on HIV. They are interested in pandemic preparedness and global health surveillance. I would say that's about it. And in order to do that, they're interested in selling American drugs, American innovations, American technology.
Okay. Angela, before I come to you, Tabika, did you want to also make a comment?
Yeah, just to add to Austin's point, two other things that the US government specified is so linked to what Austin just said, commodities specifically, and also health workers. So they have called out community health workers and nurses and investing in salaries and benefits for them. So just wanted to add that as well.
Great, thank you. And Angela, what are your thoughts?
No, well, excuse me. I was just going to add to what Austin essentially highlighted the global health strategy that the American government put out and what the plan forward there or the intentions there was. And I think between Austin and Tibika, the areas are all highlighted, HIV/AIDS, some malaria and TB, but also a strong interest for sure cutting out the NGOs because they think that that's an inefficient way of doing business, especially the business of aid. But going more to the front line, which is where community health workers hopefully will get some good support there, as well as commodities, and some of that tied to making sure American produced R&D and things find market in low and middle income countries as well. So clearest indication there is what has been published in the Global Health Strategy.
Okay. And an audience member asks a question about that strategy, and and he wants to drill down a little bit. What he's asking is this realistic given the inherent narrow fiscal space in some of these countries, moving towards, these country co-investments?
And here it's more for personal opinion slash slant here. I think the question is less of whether it's realistic, but more, I mean, this is the context you're in, and in some contexts it may be thought of as unrealistic, but I think countries are going to have to try and figure out a way to do what they can within the time frame that they've been given. And I think the feedback that the aid cuts were abrupt was received, and so they're given what 2 or 3 years. And I think with that 2 or 3 year time period, countries have the window. They've indicated what their end game is. So countries need to figure out uh, how to, even if not achieve that particular target, move closer to that because it's very clear aid as it was done historically, it's not the way we're going to do it going forward. They're not going to be given aid to, until perpetuity. We don't know what we're getting out of this money that we're putting out. So things will have to change. And even if ultimately, and I think, to be honest, I think for some countries it's very realistic. There will be some countries already, I think Austin flagged that as well. That's not realistic. But hopefully with time, right, you don't get to your goal at the first strike. Hopefully with time, given the new trajectory, countries will gradually, if not within the 2 years, at some point closer than what's in the existing or the previous system would have happened, they'll move closer to a place where health is prioritized enough that even if they have a small budget, health gets what it needs as an important driver of the economy.
Yeah.
So,
And one of our audience members also talks about the importance of challenging the private sector to get more involved and to do its part. Charles, what did you want to add?
Yeah, no, just to agree with Angela, that we have had, at least on this side of the world, experiences with co-financing models. I mean, Global Fund has been running a co-financing model. Gavi has been running a co-financing model, and there has been traction. And when the abrupt cuts happened, there was this whole view of we could do it with as a transition in a gradual manner. So we're likely to see that happening. We might not land on the sun, but we might end at the moon.
Wonderful. All right, so let's go to a few more questions before Angela's next presentation. And one audience member asks, where did the project financial data for discontinued USAID funding projects come from? If from various US government websites, some of that data will likely be wrong or missing or incomplete. So, Angela, can you talk about that a little bit? The data for the discontinued USAID funded project?
Absolutely, yeah, and thanks for that question. So this is a data set I think that has been curated by we downloaded it directly, I believe, from the CG Dev website, but it's a data set that uh, was curated from various sources, submissions to Congress, publications from the Dodge, and then there was a little bit of crowdsourcing that has gone into sort of like cleaning this data uh, based on people who had contracting experience in the US government. And so reviewing the data and the information that had been published to be able to tell which of the projects were terminated in actuality versus which ones were already terminated. And so I mean, the spreadsheet comes with a summary tab, right? That tells you which ones are active, terminated, maybe terminated and modified, likely ended, likely terminated. So this is not just us pulling data from various websites. This is, I believe, a website that was a data set that's curated, crowdsourced with people with some expertise in government contract and leverage and what publicly available data had been put out.
Okay. And another audience member asks, is there any analysis that could be done or has been done to understand where we could see a better financial investment compared to those cuts in health?
Not that I'm aware of, but certainly something that's will be interesting to look at. So, if I'm understanding correctly, what this question is about, any analysis that has been done to look at other sectors that the money could have been spent on with better returns, outside the health sector, or just still in the health sector, but other areas or yeah, other focus areas that would have gotten better returns.
Great. And another audience member asks about alternative sources of funding for small community-based implementing NGOs in sub-Saharan Africa. So as some of these smaller organizations do look for alternatives, are the panelists aware of alternatives or places to look for such alternatives?
I think somebody already highlighted private organizations as well as foundations. It's for sure the era of major bilateral funding. We seem to have transitioned out of that. So I would focus, and I'm learning myself as well that getting funding is related a lot to relationship building. So relationship building with local philanthropists, of which there are some in every country, as well as some of the major private organizations that can be found in countries. But you always have to be clear, what the asks for when you're going for some of these other sources of funding.
Yeah. And Charles, before I come to you, just to note that one audience member, for example, referred to family offices and institutional capital and some of the priorities there that tend to be maybe more tech focused, and whether this is a moment to think about reframing some of those approaches. So Charles and then Tabika.
Yeah, thanks very much, Rhonda. For non-government organizations, we are seeing two trends. One, we are seeing a pivot towards social contracting. So governments are beginning to step up and actually fund community organizations to continue the life-saving mission. But two, we're actually seeing some kind of strategic repositioning by community organizations to actually deliver things more on how do I call it? There's a social enterprise. So there's a lot of social enterprise models emerging, and I think those seem to be pointers to how things ought to be in this radically changed context.
Absolutely. Tobika and then Austin.
Yeah, really quickly, just to add to that. So Angela also mentioned local philanthropists, but we also see in this with global philanthropists and private foundations who are investing in community-based organizations. And because Community Health Impact Coalition, we're made up of these health organizations who are locally implementing and delivering service and care. So what they're also doing is they're able to collaborate with some of these multilateral institutions like Gavi and Global Fund and implement through some of the funding that comes through these multilateral institutions as well. So although we're seeing some of the cuts, there's still some prioritization of community-led interventions.
Absolutely. Austin.
Yeah, no, I probably older than most of you. So, when I started working, there was a very different understanding of community-based organizations. And they were genuinely raised out of the community and started working within and for the community without external assistance. And it was the best ones that then caught the attention of aid, and it was a way of getting closer down and providing service that were trusted through a trusted agent. And over time, I think that's just become the paradigm, is that many agencies have got used to receiving international finance. And the problem with that is it bureaucratizes them, because they have to then get used to writing long proposals to people like me with lots of risk matrices and results frameworks and KPIs, and then they have to report on that. But, at the beginning, they couldn't do that, but they were really of the community. And I think what we might see is a return to a different kind of social activism that isn't so respondent to a market created by lots of donor aid flushing around. And that might also be positive as well in some ways.
Okay. Very interesting. And Austin, let me also ask a question that an audience member had for you, which is that you'd mentioned there is so much fragmentation in health financing, having as consequences the duplication of financing in some domains. Don't you think that global health, if well implemented, can also reduce those duplications while still producing better impact?
So a little bit what I was saying is that global health has become very fragmented in its institutions. So I'm not sure how doing it reduces that fragmentation. To be honest with you, I don't. The thing that in my experience reduced duplication was the MDGs. It had 3 targets, and all donors committed to it. So even though no donor can ever commit to doing exactly what the others do, they all started funneling their financing towards very specific targets. And I think that logic was described by yourselves, Angela's colleague Joe Dielman, as the golden era of global health. That logic is, as I said before, very American in a way. And I think other formulations of institution building and maybe got swept away a bit. But I think what the problem with those very focused agencies and goals is, you do have success because you report directly on, but you then have to set up another one for the next problem and another one for the next problem. And so as you have success, new problems emerge and new institutions emerge, and there isn't more money, and there's more boards and more problems with all the governance structure. So I don't see that way of doing business as by working reforming itself. To be honest, I think it drives the problem worse. I think we do have an opportunity now to get better, but it's an opportunity, it's not an historical inevitability. I do think that there is a realization that we're no longer in 2005, and the voices of those we serve and the voices of countries have to be much stronger in determining both priorities and methods.
Yeah.
But that comes with responsibilities as well, and that's where we're not getting yet to a new formulation. We can call for listen to us more. It's us that you're helping, but then but that's not power. That's just a request. You have to. Power is not given, and power is taken. And people in the South have to take power back and partner properly to reform aid to make it work the way that they want to. Okay? It sounds a bit hard, but I'm not trying to be hard. I'm just trying to be realistic.
Okay. All right. And another question we have, Tabika, let me go to you first before I get to the next question.
Sorry, yeah, really
Oh, you're
quickly
fine.
on Austin's point. So I agree with the fragmentation of global health architecture, and that's where I see these aid cuts are really forcing these institutions to think differently and even act perhaps in a less fragmented way. And this is where the Lusaka agenda, which when it kicked off, I think around 2023, had good intentions, but didn't really see much materialize. But the plan was very much about one plan, one budget, one M&E, and it's making sure that all these different global actors are coming together to help or support countries' own priorities. So that's where I wonder, Austin, as well, you mentioned the HealthWorks initiative, for example, of the World Bank that is working on these country compacts that are meant to be more two-way, and where I've seen the Global Fund and Gavi are also involved. So I guess the question, are you seeing some of what's happening now, perhaps forcing these global actors to come together and work in a less fragmented way for the countries that, as you said, for example, like Sierra Leone, who will still need some support as they're thinking about transitioning to domestic resources at some point?
I don't want to speak too much. I don't see that. I do see that big actors are getting more involved in a two-way street. So US, World Bank. But I don't think that means it's defragmenting. I don't see any agency that's collapsed or been closed voluntarily, apart from a few American ones. But I think they will. And I think in the next 5 years, just in my long experience, when I first came in, there was something called the H4 in the UN. So that meant 4 major agencies involved in health that tried to coordinate with each other. I think the last count, it's the H20. No one decided to go from 4 to 5 to 6 to 7 to 8 to 9. It's because there's so much money in health that all agencies have their own mandates and they decide and they got a country to fund a program. So more and more UN agencies got involved in health just because of the money supply. That's not helpful. There is no architect. This is happening because of money streams and different individuals. I don't know what the right H number is, Charles. I'm not going to talk about whether UNAIDS should or should not be closed now. But it's just indicative of how these things happen. And I think we're going to have to see a reverse. Some UN agencies will decide it's not lucrative to be in health and they'll withdraw. NGOs will shrink and reduce their portfolios. I think some, particularly consultancy agencies, will collapse or will get out of service provision to the aid agencies. They'll continue to the private sector. But I think Rhonda's question was very interesting. What do we think will be the reaction of indigenous private sectors, in particular, if we see this re-socialization of NGOs in country and the social power of NGOs linking up to local businessmen? Are they able to start to bend investment patterns to contribute socially within their countries to a greater extent or not? I think that's interesting. But as I said, this is not history that is determined. This is for the making.
Country should take within the next 2 or 3 years to ensure that sustainability for health services is not disrupted, especially given that there is obviously less funding to ensure that health systems strengthening work continues? Angela, do you want to take that one first?
I will go with I think that the countries or some of the countries already have the path, which is Austin said earlier, it seemed harsh, but I think countries taking back that ownership and leading and becoming more or taking more leadership and ownership of how they are funding their own health sectors. I think the push for domestic spending was this has gone on for a while. Hopefully, Charles already mentioned that Accra Reset. Hopefully, this is the momentum of all momentums, and this is where we make that great transitions. Fingers crossed. Uh, uh, because I think the narrative, to some extent, also sometimes feels like the health sector is not a productive sector. We have research that has shown that investing in health has multiple economic benefits, labor productivity and the such. So whilst we facing most countries may be facing a challenging situation regarding tight budgets and allocating, I think taking the perspective that investing in health could actually be a thing that has additional benefits and not just an extraction or an input source with no returns will be a perspective that hopefully can spare the needed increase in ownership in low and middle income countries for domestic finance, and whilst keeping that concept of a one health plan, a one plan that has different actors funding different aspects will be the way to go. So
Great, thank you.
Hands up. So
Charles, Tabika, and then Austin.
Yeah, thanks very much. I think that's a very important question. My quick reflections is that we need to recognize two things. One is that the countries are facing simultaneous transitions. While for us who work in health are thinking about, it's transition from this development assistance partner, the countries are facing transitions from IDA. There are multiple transitions happening at the same time. And I think it's important that we take a step back because the demands are on one country, whether it's for health, whether it's for infrastructure. So it's going to become that we have that macro view of what transitions we face so that and I think the second is to really recognize that sustainability is not just going to be about money. At UNAIDS, we view sustainability, not just financial sustainability, but political sustainability, keeping things on the political agenda. And I think there's a role for holding duty bearers accountable to keep health on the political agenda. And the other dimension we always think about at UNAIDS is really the programmatic, that we do things that make the most difference, the most cost-effective things, making sure that we implement things that really make sense. And we can argue, but that's where we're going to gain a lot of efficiencies. So what do I see as pointers? It's really beginning to address the big elephants in the room. Let's address the debt issue. I just had a meeting, I think, like 2 weeks with the African Union Ministers of Finance and Health. And it's clear that they are not some of them are not defaulting on public debt. But what is happening is when you have investments in health and education 7 times more of that is being spent on debt servicing, they're actually defaulting indirectly on providing services to the citizens. And I think we need to find a quicker solution. There are no simple answers, but we're also going to, certainly efficiency, we are going to leverage private sector because it remains one of those pieces. And we're seeing social impact bonds being launched in places like South Africa, in Kenya. And I think therein lies the prospects of leveraging the potential of the private sector. But critically, we're going, and I like how Peter has brought to the fore tougher questions. We have these revenues that we forego from collecting, so-called tax expenditures. whether it's in subsidies, some of them don't make sense, but they're important sources of revenue that we've been foregoing as countries. Maybe it's time to really pick that up. And I want to end this with actually a statistic from Africa. About 89 billion US dollars are lost through illicit financial flows. We need to plug those gaps so that we channel. When the pie grows, then there is so much for all the other critical things governments want to do. If we plugged that leakage, we could actually comfortably finance some of the health issues that we care about. Over to you, Rhonda.
Wonderful. Thank you so much, Charles. Tabika and then Austin.
Yeah, really quickly, I feel like Charles really covered it comprehensively, but maybe just to add one more point, as I briefly mentioned this. So something that we've been hearing working with countries is that you have to make the case to the Ministry of Finance. And typically the Ministry of Health is not necessarily seen. We talked about fragmentation and that there's so much fragmentation because it's very disease focused. And again, that's also been pushed by some of these global funders who had very specific disease focus. So when the Ministry of Health then tries to make a case, it doesn't seem jointed. It's not necessarily linked to the return on investment that Charles mentioned. So there's definitely a case there to be made of how do you, for example, in our case, we make the case of why is investing in community health workers cost effective? What's the return on investment? Why is that dollar, whatever, whatever we're thinking about, not dollar necessarily, but why is that money well spent on health specifically, on the various interventions? So that's just one piece that I wanted to add to that. Thank you.
Yeah, absolutely. The need to break down those silos between the ministries of health and finances is absolutely critical. Austin.
Yeah, I wanted to say that as well. I don't think it's just about telling Ministry of Finance what's cost effective. Presidencies have to bash heads together and get both ministries of health and finance to work together. And there is a lack of will on both sides in different countries for different reasons, but in both sides don't want to work with each other, and that's just not acceptable anymore. You cannot build a health system without economic intelligence. It is not just public health doctors who build a health system. So that's really important. I would say the other thing for LMICs, lower middle income countries and high middle income countries, they can do this. It needs the political will, number one. They have to say to their systems, we're going to get serious about this and organize that. Where are they going to look? They need to look beyond just loss of money. There has been a very important procurement function of global aid. So they need to be able to get into the business of buying quality drugs at low price. African countries usually spend a lot more on drugs than other countries. Much more. So the poorest people get the most expensive drugs. And data. Almost all data systems are heavily subsidized by aid. And African countries need to build their own data systems. You cannot run a good health system without data. And that needs to be seriously thought about, that evidence-informed priority setting has to take a much, much bigger role if we're going to reap the efficiencies that Charles talked about. And some of these efficiencies need to be done regionally, some of the procurement and data issues. So the African countries need to start building regional agreements and working together. And I'm not quite sure what to do about the poorest countries. And I hope that in the end, the very few LICs left will continue to be subsidized, but with a more deliberate attempt to leave governments with responsibility and to move more quickly in that direction.
Absolutely. Thank you. So, Angela, let's come to your next presentation in a moment. And I also just wanted to acknowledge a question from an audience member who asks about the likely outlook for the upcoming years, considering the geopolitical and economic dimensions. So you're going to be talking, Angela, I know, about sort of what comes next. And so why don't we get ready for your next presentation, which is actually going to be on the case studies of country responses. And it's worth noting that we have really fantastic country representation on the call. We have colleagues from India, Pakistan, Kenya, several cities across the US, Copenhagen, many places. And so really understanding the country responses, I think, is going to be really relevant for people. We're also going to have a Zoom poll that that Ian is going to share on which of the approaches Angela shares might seem most promising for your context. So get ready for that poll. I do also want to address Tabika before she needs to leave us. Thank you so much, Tabika, for contributing to the conversation. Really great to have your perspective. So Angela, let's turn to you. And you will want to unmute Angela once you've got your presentation up. Okay. All right. So Angela,
sorry about that. Yes.
No worries. All good.
All right. Thank you. And in this presentation, I'm going to share some ongoing, very preliminary findings from some ongoing work we currently have. And this is focused on the domestic response. So all we've discussed so far, at least what we did with the report initially, was to quantify the magnitude of the cuts and to just get an understanding on what's happening. I see this as the second arm, which is now trying to understand, okay, so these are the magnitudes of the cuts. What are countries doing? How are countries responding? So to that effect, what we're doing with this project is, as a phase one, developing country briefs to understand what's happening in each country. And we're taking this particular approach because you will all appreciate, I'm sure, that the responses are going to be nuanced and very context specific. And so far we have we've completed briefs on Nigeria, the Democratic Republic of Congo, Niger, Kenya, Senegal, Tanzania, Pakistan, India, and Indonesia. I'm not going to share results from all the 10 countries. I'm going to highlight three just as a way to show the diversity of response that we're talking about here. Before I get to that, I'd speak to the data sources that we've relied on for the briefs. We're using latest updated development assistance data to understand what the potential gap in the aid funding will be. We're extracting government allocation to the health sector from budget documents, so national budget document, to see what the official allocations are from the government perspective, starting from 2023 to 2026 as available in each country. We also pull in some macroeconomic variables, growth rates in GDP, tax revenue, health spending, health sector efficiency scores, as a way to do a very rapid assessment of the potential fiscal space there. We are talking a lot about governments picking up, but as our panelists already highlighted, that would vary depending on the country context. And so here are some initial results with one or two caveats before. In addition to the data sets that we are using, the quantitative data sets, we're doing I guess we'll call that qualitative interviews as well, speaking to interviews with local experts that we're connecting with through our GBD collaborator network to give us a more on-ground input on what the responses have been. I caveated with the fact that these are preliminary, and I think in some instances we see that there are changes that seem, from the country perspective, from our perspective, will seem to be new, but some of the countries have been making changes prior to the aid cuts. Charles mentioned earlier previous country experiences with co-financing. So just caveating the results that I'll share with that. That said, I will highlight three countries: Ethiopia, Niger, and Indonesia, with the goal of just showcasing the diversity in responses here. We start with leveraging our development assistance data to try and understand what the potential gap could be here. This is a simple analysis where we start with what in level space what the spending was in 2024, with the assumption that that was the phase where we had no major aid cuts. And so that's what we see in the first block, in the first figure, reporting the health spending gap analysis. So we have the spending from the different sources, right? Government as blue, development assistance as green, out-of-pocket spending as orange, and prepaid private as purple, right? And so in Ethiopia, we see out-of-pocket spending is significant, but development assistance was too. And then in the next bar, we implement what we have estimated now as the cut. So we see that as a 32% drop in their aid budget for 2025. And then hold the government spend constant there for a minute. But change or account for potential increases in out-of-pocket spending and prepaid private spending. And then in the last bar, we also implement what we have pulled from the national budget as the allocation to the health sector for 2025. So that's what's shown in the bar figure to your left. And we see that in Ethiopia, government spending or government allocation to the health sector is said to increase. But also out-of-pocket spending will increase to different degrees. Moving to the next, the middle bar, we see I'm reporting the results from the rapid fiscal space assessment, where we're looking at the growth rate, recent growth rate in GDP, to sort of capture just the overall envelope, the likelihood that the envelope is overall government envelope is increasing enough that there will be an opportunity for more allocation to the health sector there. Government revenue as a share of the gross domestic product, or tax revenue as well. Again, capturing sort of the overall bucket of money government has access to, or the potential to raise more money internally from government covers. And then government health spending as a share of general government spending to give a sense of government's prioritizing of the health sector. And then, there's, maybe we haven't, Charles may have mentioned it, and Austin as well, this idea of efficiency in the health sector and making sure whatever dollar or resources we have is utilized very well. And so we have some analysis from a different study that generated health system inefficiency scores. So we pull all of that together in that rapid fiscal space assessment to get a sense of where countries may be able to potentially increase spending for the health sector. Ethiopia here is the black line, and then we've plotted either sub-regional averages or the overall regional average as a comparison, so that if there are other regional countries doing better, we highlight that as the gap that the country, or the potential that the country itself could do better. And then lastly, so with the fiscal space assessment, for Ethiopia, we see in terms of gross domestic product rate of growth, the economy has grown at a relatively high level compared to other economies in the sub-region. In terms of gross government revenue as a share of their gross domestic product, they're compared to the regional average, they're a little on the lower end, but that's exclusive of tax revenue. So government revenue could, from other sources, could potentially be increased, not necessarily from tax revenue. Prioritization of health sector looks like there's opportunity there as well. But in terms of inefficiency, they seem to be doing relatively better compared to the regional average. An important part of all of this is to be aware of some of the political economy considerations. So if you were just to stick with the results of the gap analysis, I think your initial assessment will be like, oh, wow, Ethiopia has increased spending quite significantly. But here are the caveats to that. The health sector budget has tripled recently because the currency has been devaluated. But also, the government has improved its taxing system. So you can see, in the figure C there, that the tax revenue is higher than the regional average. And also, the Ministry of Health has been quite deliberate in terms of advocating for resources. So the context is that with the budget, the devaluation in currency and the budget aid cuts, the ministry was able to pull together some data highlighting the challenges facing the health sector in light of the devaluation and the cuts. And this was presented to the Ministry of Finance, and, echoing some of the earlier discussions we had. And with that, they were able to manage to negotiate more allocation for the health sector. Additionally, they've also piloted what some will consider innovative methods of health financing, largely focused on a particular health area. And so in the sector, they've used a family planning compact where with government co-financing, they invited other donors to fund particular commodities and services related to family planning, and this has turned out to be very successful. So much that they're thinking of developing another one, I think, related to helping to fill the gaps related to health worker shortages. They have also actively engaged other donors, including other Arab donors and donors from foundations. So that's the summary for Ethiopia, which shows a country that seems to have responded quite robustly. I'll highlight Niger, which is, in my assessment, feels like a country, one of the countries that Austin has highlighted in terms of potentially need an extra support. So we see that for the spending gap analysis, Niger has some aid cuts. However, government spending for the health sector is already decreased, at least in the budget. They haven't released the new budget since the aid cuts, but in the budget that was released before the cuts, the health sector allocation already went down. This, has implications for out-of-pocket spending as well. In terms of the fiscal space assessment, we see that their economic growth relatively is also high compared to the other regional averages. However, there's opportunities in increasing just the government revenue share of GDP there, and that remains mainly the area with opportunity. For now, it seems like if compared to the regional averages, the health sector, although the allocation may be low, seem to be prioritized higher. And I think that's related to the overall share, the overall pie that we're talking of here. In terms of inefficiency, they seem to be doing generally quite well with the envelope they have, and that's something to be highlighted. A key political economy consideration here is that there's a little, bit of instability in Niger now, and it seems, in some of the media reports, it seems that the government's more immediate priority is in improving security and prioritizing military spending in the country. And so I highlight this to show the diversity in responses that we're looking at. The last one I have to highlight is Indonesia. And Indonesia starts from a completely different space. You can see from the gap analysis that health spending, government health spending in Indonesia has increased significantly recently. And most importantly, whilst Indonesia, as a low middle income country, gets some aid, it's not donor dependent. And so, going forward, all of this concerns related to aid cuts will have relatively muted impacts there. Summarizing in terms of emerging takeaways here, we see, we can think through our potential responses through three arms, largely shifting towards domestic resource mobilization, encouraging multi-sectoral partnerships and some innovative financing mechanisms, as well as technological innovations, hopefully to help stretch limited resources and improve efficiency in the health sector. The key takeaway there is that I see diversity in response, but a lot of that is also linked with the country's economic standing and existing in-country macroeconomic factors. And that's all I have. We can launch the poll with an invitation to you all to respond on what of these three potential domestic response channels you see as most applicable to your context.
Angela, could you put those back up, the slides?
Absolutely.
Great. And let's launch the poll. And then after we take a moment for that, we will move to the final part of the presentation, which is charting the way forward. So there we go. So Ian, we're ready for the poll if you want to get that up.
Okay. Oh, okay. We have people still voting. All right. So, interesting. I think the majority of us feel that multi-sectoral partnership and innovative financing is the path forward, with shifting primarily to domestic resources and efficiency improvement in a almost a close tie with efficiency improvements having a little bit of a lead there, but yeah.
Looks like the responses have slowed down, so we'll go ahead and share the results. A few more seconds. Okay, let's click share.
Great. Very interesting.
Yeah.
All right. And so let's conclude the session by talking about charting the way forward. So, Angela, do you want to lead us through some comments on that?
Absolutely. I think we have highlighted the real challenges ahead, emphasizing the different contexts and areas where countries may face challenges in terms of filling in the gaps that the aid cuts have resulted in. I would love to hear or get your participation in what you think. One word, and we will launch the word cloud here. If you could chime in one word that in how you think what government, donors, or communities can do to mitigate harm and sustain progress as a way forward.
Let me share my screen. We have a word cloud pulled up.
Yes.
You can either use the QR code that is there, or I'll also post this link in the chat.
So just one word responding to what you see or what you think governments can do, government, donors, or communities can do to mitigate harm and sustain progress.
Seeing some responses coming in.
Yes, very exciting. Ownership, collaboration, engaging. I like step up. Evolve. Evolve seems like an appropriate response. The terrain certainly has changed, and evolving to suit the new landscape will be a good thing. Accompaniment, that's interesting. I would presume that's speaking to partnerships, but there's also policy improvements. Collaborate is still has a strong support. Invest. I consult with citizens, listen, rationalize. Transparency, that's all interesting. Anti-corruption. Ownership is getting more support. Care of own. That's all very appropriate responses. Financial protection. I'll give it another minute, and then we can wrap this up. I love the words that we have suggested. DRM is also important. But I would want to wrap up with this. And it sounds like a lot of us feel that going forward, governments, donors, and communities, it will be important that they collaborate, that there's ownership from the perspective, I imagine, of the government as well as the communities, and maybe more partnership and collaboration from the donor perspective, but not neglecting the importance of keeping accountable, being transparent, and listening. Thank you all for sharing your thoughts here. I will pass it back to Rhonda with 5 minutes left to wrap up. Thank you.
Yeah, thank you so much, Angela. Let me just say thank you to all of our panelists, to Angela, to Austin, Charles, and Tabika for providing just really rich and actionable insights. Thanks also to our audience for so many great questions. We unfortunately don't have time for all of them, but really just it was so valuable and so rich to have people from different sectors and different countries chiming in with their questions. Thanks also to our hosts at CUGH, to Ian, to Dr. Keith Martin and team for hosting this really important conversation and this entire week of really important conversations. I also just wanted to note that in the chat, I did share a request from Dr. Martin about ways that people can share their stories with CUGH. So these might be stories, they might be videos about how these aid cuts have played out in your own work and in your own country. So please do that. Also, as Ian said, this session will be shared as a recording, and he's going to be saving the word cloud as well to share those responses so that we can refer back to those. So with that said, Angela, any final words to you, or Austin or Charles before we wrap up?
I think I've said plenty for now, but thank you to all that joined. It was indeed a very rich discussion, and we look forward to seeing how all of this plays out in the next year and so.
Thank you, Rhonda. Thank you, IHME, for the reports.
Wonderful. Well, thanks again, everyone. Do go ahead and download those reports, look at the data visualizations. There's a lot of information there for you to make use of. Thank you so much. And that will conclude the session.